Okay,
Yep.
wonderful. Well, thanks so much for the invitation to come and speak with your group. I think this is a really wonderful series, and great to bring our paper to your group this week. So my name is Josh Rosenblat. I'm a psychiatrist by training. I spend about half my time doing research and half my time doing clinical care, but all of the research is clinical research, focused on clinical trials and real world evidence. So all very much connected to mood disorders. I'm affiliated with the University of Toronto, but the work I'm presenting today is primarily from our community clinics, the Canadian Rapid Treatment Centers of Excellence. That's now in a name transition to Braxia Health, as it's part of a larger company, Braxia Scientific. So the paper we're discussing today is real-world effectiveness of repeated ketamine infusions for treatment-resistant bipolar depression. This paper was led by Farhan, one of my graduate students who is attending today as well. Was initially going to have him do the presentation, but I understand that there's a lot of clinicians in the audience and wanting to have some clinical perspectives as well. So decided that that I would present, and then he can add some comments as well as needed at the end also. This is I believe a very important paper because of how malignant and challenging bipolar depression is to treat. And on a personal note, this was a very rewarding paper as well, as Farhan is actually my first graduate student. So this is my first graduate student's first author paper. So there's a personal connection to it as well. So glad that we can discuss it today together. So I understand this group is very familiar with ketamine, so I'll scrap the first 5 standard slides that we all see about background of how ketamine works and how promising it is, and just focus in on ketamine for bipolar depression. So bipolar depression is certainly a very severe form of depression that treatment resistance is really the rule rather than the exception. And there's this huge challenge where suicide rates are very high, with 5 to 10% actually dying from suicide, being victims of suicide. So very few illnesses in medicine that have early mortality at this high of a rate. So I often say to my residents that if you want to save lives, treat bipolar disorder, because this is where people really are dying in psychiatry. Because of the high rates of suicide, ketamine is particularly appealing due to the potential for reduction in suicidal thoughts. Also, because there's such limited approved options for bipolar depression. So we have lithium, lamotrigine, lurasidone, quetiapine, cariprazine, lumateperone. So in the last couple of years, with cariprazine and lumateperone getting added, there is some additional options, but still, this is a very small list when you compare it to, for example, unipolar depression, major depressive disorder, where we have dozens of approved antidepressant medications and augmentation options. For ketamine specifically, we all know that it's been fairly extensively studied now for unipolar depression, or MDD, whereas for bipolar depression, some studies have allowed for inclusion, and they've had a few sort of token bipolar depression participants. But for the most part, it really has been research in unipolar treatment-resistant depression, with only 3 small single-dose RCTs completed to date thus far with bipolar depression specifically. There's also this theoretical concern of treatment-emergent mania and psychosis with ketamine and psychedelics in general that raise caution for use in bipolar disorder. And I know many clinics that would exclude people with a history of mania or hypomania or psychosis due to concerns of them having a vulnerable brain and this potentially being too risky of an intervention. We are doing some research also in psilocybin for bipolar depression and seeing if it really is as risky as everyone thinks it is, or if it's similar to ketamine, where perhaps the concern was greater than the reality of the theoretical risk. So happy to talk about that at the end too, if there's interest. So specifically for bipolar depression, as I mentioned, there's only been the 3 RCTs. So this was a review completed by Aniqa Baji, who's also a Canadian psychiatrist. And as you can see here, there's only 6 studies, and only 3 of them are RCTs, and 2 of those are crossover RCTs that I think we all have a certain skepticism right now with ketamine, given the variable duration of benefits and carryover effects, where we're really talking about a relatively low level of evidence. And when you look at the sample sizes, we're talking about samples in the teens primarily. So a total of 135 people in this review paper. That's fairly up to date outside of the paper that we just published. And if you look at the clinical trial specifically, we're talking about less than 50 participants worldwide that have been enrolled in RCTs with ketamine for bipolar depression. So very small numbers, but the initial results being fairly promising in the clinical trials and open label studies, suggesting similar rates of efficacy and safety comparable to the excellent antidepressant efficacy that we've seen for unipolar treatment-resistant depression. Importantly, only a couple cases of treatment emergent manic symptoms seen in these clinical trials. So the initial signal suggesting that probably the risk of treatment emergent mania is not as high as some might think, or mood destabilization with ketamine in this population. But again, small numbers, so more research needed to have further confidence in these results. So that sets the stage for our study, which is not an RCT, but is a RWE, or real world effectiveness study, that we're doing in our community sample. So real world effectiveness data is really growing in popularity, with this recognition that when we translate findings from clinical trials into clinical practice, there's often a disconnect where things might work very well in one setting and not as well in another, when you add the complexity of comorbidities and you're starting to treat all the people that would typically be excluded from clinical trials. So in our community clinics, the CRTCE, we actually have 6 sites now, but for this study at that point, we had 4 sites. And we're a community practice where we do not exclude complex or difficult to treat patients. We include ultra-resistant depression, bipolar depression, all the comorbidities, personality disorders, history of failed ECT, medically complex, and even actively suicidal people. So people who are even admitted into hospital involuntarily might be eligible to be transferred on passes to our center to receive ketamine. So these are not your typical RCT candidates, where a lot of these participants would actually be excluded from participating in clinical trials, but allows us to really capture the real world patients that we all treat clinically and we know are challenging to always extrapolate and generalize from the clinical trial data. So this is the broad eligibility criteria for our clinic, and it applies for this specific study as well, where we're looking at the subgroup with treatment-resistant bipolar depression. So we use the typical standard definition of failing at least 2 adequate medication trials during the current episode, so not just lifetime, and they do need to be adequate. So one of the big focuses of our consultations is really getting a sense of where these actual adequate trials is this actually treatment-resistant depression that we're dealing with. Exclusion criteria are fairly minimal. So if they're medically unstable, one of the main things that can come up is uncontrolled hypertension, where, of course, given the treatment emergent increase in blood pressure, we would want to make sure their blood pressure is adequately controlled. If they're unable to adhere to the protocol, pregnancy, in specific situations, we have actually waived this eligibility criteria, but not in the sample that I'm presenting for you today. Or if they have a current or recent active substance use disorder. Importantly, we do not exclude comorbid personality disorders, active suicidality, and of course, we do not exclude people who have a history of mania, hypomania, or psychosis, who are the focus of the study I'm presenting today. This is the treatment protocol that we use for our acute course, where we're administering ketamine infusions twice weekly for 2 weeks. After the second infusion, if they have had inadequate antidepressant effects and they're tolerating it adequately, we would offer a dose increase to 0.75 milligrams per kilogram, and that would be the potential dose for the 3rd and 4th infusion. Everyone in our clinic has to be referred by a physician or healthcare provider that agrees to continue to follow the patient, and they have to be in agreement for ketamine. So I know this is quite variable at different parts of the world, where sometimes self-referral can happen, but we are part of a larger care team. Everyone would meet with a psychiatrist for a comprehensive mood disorder assessment, confirm the diagnosis, and determine if they're eligible. And then we would be doing measurement-based care throughout the course of treatment, measuring the self-reported depressive symptom severity through the QIDS, and also the GAD-7 for anxiety and the Sheehan for functional, subjective functional impairment. This study is an ongoing chart review, real-world effectiveness study that is registered with clinicaltrials.gov as well. So you can look up the NCT number there if you want more details about it. So getting right into the paper, we wanted to focus in on treatment-resistant bipolar depression. When I started treating patients with ketamine, I was actually quite surprised to see how well the patients with bipolar depression were doing. And in many ways, my initial subjective clinical impression was that the patients with bipolar depression were actually doing a lot better and having greater magnitude of benefits as well as longer lasting benefits compared to my unipolar treatment-resistant depression cases. So that was really the impetus for this study, as well as a series of other studies we're now doing in bipolar depression. So we wanted to look at this more systematically using our measurement-based care real-world effectiveness data. So we looked at the subgroup of people in our database with bipolar 1 or 2 depression, and this included 66 patient participants. So here's the demographics, so nothing too surprising here. Mean age of around mid-40s, a fairly even split between males and females, as would be expected for bipolar disorder. BMI on the higher end, certainly we all know bipolar disorder is associated with overweight and obesity. Focusing in here that certainly we are far past the 2 failed trials for most of our patients, where often people have failed over a dozen medication trials, but the mean being around 5 or 6, and most of them being on 1 or 2 treatments when they're going in for the treatment. Not major differences aside from baseline depression severity that I'll show on a subsequent slide between the bipolar 1 versus 2 subgroups here, which was a fairly even split as well, 28 in the type 1 and 35 in the type 2. So this was our primary outcome of interest, looking at the reduction in the QIDS, Quick Inventory of Depression Self-Report 16 item. So on the y-axis here is the QIDS scores, and focusing on the blue line first, this is our entire sample of bipolar depression, including type 1 and type 2. And as you can see, there's a fairly clear incremental reduction with each subsequent infusion for further reduction in depression severity, with a mean reduction of around 6 points. For those of you who are less familiar with this scale, for treatment-resistant depressive disorders, the MCID would be considered around 3 points. So 6 points certainly being a clinically significant difference, doubling the MCID for the QIDS. What we found was that there was a trend for even further reduction in bipolar 2 depression, as you can see with the gray line. However, when you corrected for baseline severity, there was no between group difference between bipolar 1 and 2. So even though there's a trend suggesting that perhaps bipolar 2 depression has a greater antidepressant effect with ketamine compared to bipolar 1, this wasn't statistically significant. And certainly one of the issues could be the small sample size here, that we might be inadequately powered. So that would be a very interesting question to test further moving forward, if this actually is primarily a treatment that would be best for bipolar 2 depression, which notably has a greater period of time in the depressive phase. So often we are struggling with treatment-resistant bipolar depression, even more so in bipolar 2 disorder. This was actually a publication from a couple of years back where we included both unipolar and bipolar, looking specifically at agitated depression or mixed depression, where mixed depression or mixed states in bipolar disorder are particularly difficult to treat, high rates of suicide, high rates of treatment non-resistance. But what we found using the AIA, agitation, irritability, anxiety criteria that was validated previously, that even in the group with agitated mixed depression, they did just as well, if not better, with IV ketamine. And this included 15 people with bipolar depression. So it appears that even with bipolar depression with mixed features, there's a fairly robust antidepressant and anti-suicidal effect, or reduction in suicidal thoughts more specifically, with repeated IV ketamine doses. This is the table 2 showing the specific numbers in terms of the further reduction. So just drawing your attention here at the depression symptom severity, really highlighting that with each subsequent dose, there was a further reduction in depression severity. This is important to highlight because, as I mentioned earlier, that the previous studies were just single dose studies. So we know for MDD that repeated doses leads to further reduction in depressive symptoms, but this provides some good preliminary evidence to suggest that for bipolar depression as well, you get incremental additional gains with further additional infusions. With the suicidality as well, there was further reduction with subsequent infusions. Wanting to draw your attention now also to the responder and remission rates. So acknowledging that the QIDS is actually not a great scale for bipolar depression specifically and in general for measuring response to ketamine. So I think these numbers might be slightly off, but nevertheless, it does appear that after the acute course of 4 ketamine infusions, we're getting a partial response rate of around 45%. A response rate with 50% reduction of symptoms at around 35% and full remission at around 20%. Not quite as impressive as some of the previous clinical trials, but within the context of bipolar depression, certainly these being fairly exciting, hopeful numbers where, often in this population, we're looking at 5 to 10% response rates after people have failed so many medication trials. So even though not as good as we'd like to hope and that we would hope for, and we've seen with other ketamine trials, still fairly optimistic to see a 35% response rate after the acute course of 4 infusions. Very importantly, reduction in suicidal thoughts was observed. We always run into the issue of ceiling effects when you're doing a full sample analysis. So the orange line in specific was looking at participants with baseline suicidality. So in that group, we see a very clear and more dramatic drop. We did not see treatment emergent suicidality. So even in these patients that, this is a 3-point scale. So even for patients that were scoring 3 out of 3, we were able to continue the treatment. And we did observe a fairly consistent and substantial reduction in suicidal thoughts that further reduced with each subsequent ketamine infusion. Symptoms of anxiety improved as well. This has been an interesting clinical observation that I'd be curious to hear people's thoughts from the group that are clinically using IV ketamine, where I haven't been particularly impressed with the anxiolytic effects of ketamine in my unipolar depression sample, but in my bipolar depression patients, I have been more so impressed seeing that their depressive symptoms improve, but their anxiety symptoms seem to significantly improve as well. And this is what we observed on the GAD-7 generalized anxiety depression self-report scale as well. Functional improvements were observed in the social and family domains on the self-report SDS-GHAN disability scale. We did not see a significant improvement on the work subdomain, but we did see these functional improvements clearly in social and family function. And subjectively, qualitatively, this is what patients were sharing with me as well, that they were noticing that they were able to socialize more and that they were able to do more in their family units. So this comports quite well with the qualitative feedback that patients have been providing. Now, of course, very importantly for bipolar depression, this question around tolerability. You can see the paper for the full table of the rates of adverse events, but the long and short of it is it was very well tolerated, and the rates of adverse events were comparable to our MDD treatment-resistant depression group. There was 0 treatment-emergent mania or psychosis, and we do monitor for this very closely. Dissociative symptoms were comparable, and there was only 3 cases of treatment-emergent hypomania. I put the paragraph here specifically describing those because I thought that might be of interest. Importantly, 2 of those patients actually were co-prescribed an antidepressant, which might have been a factor. And 1 was not on a mood stabilizer. So with this data in hand right now, also we're strongly encouraging people to be on a mood stabilizer when they're pursuing ketamine, because if the risk of a treatment emergent hypomania is 4.5%, that's certainly a significant risk that we would want to be careful with and try to mitigate that risk with having an adequate dose of a mood stabilizer if possible. So to summarize, the real world effectiveness data for treatment-resistant bipolar depression in our sample was fairly encouraging for both antidepressant effectiveness as well as tolerability. We were able to use this pilot data to obtain 2 grants, one federal grant and one provincial grant. These 2 clinical trials are ongoing at our centers right now. 100-person RCT looking at repeated ketamine infusions. This is actually the first RCT to look at repeated ketamine infusions for bipolar depression with a target sample of 100. Again, looking at the previous studies where putting them all together, less than 50 included in RCT. So this will hopefully be a good contribution. And then also looking at maintenance of boosters over a prolonged period of time to see if we can maintain the benefits. So we really are going to dig quite a bit deeper into this question of ketamine for bipolar depression. I won't go into the details. These are just the sort of next steps. This is the clinical trial design for our acute RCT, where it's a very similar design of twice weekly for 2 weeks for the ketamine infusions. And then that is going to be followed up with our longitudinal data. This was a very preliminary look that's not included in the paper because it's too small of a sample at this point. But this provocative question of, could ketamine be a mood stabilizer and help to prevent relapse as well? And our preliminary look at this suggested that those who had a very good response to the ketamine and continued with boosters every few weeks actually were able to maintain their antidepressant effects. So that's the impetus for the second funded clinical trial, where we're going to be doing booster infusions on at a flexible dosage on a flexible frequency to see if we can maintain the gains that people have had. So to summarize, fairly encouraging results, but more data is of course needed. Limitations of this uncontrolled observational study, sampling bias from our private community clinic, placebo effects, expectancy bias, not having good long-term data. Just my kind of big push and vote for combining real world data with RCTs, where for decades, if not longer, there's been this focus on RCTs as the gold standard. But I think there needs to be more of an appreciation for combining RCT data with real world data to really get a sense of how is this going to generalize to our clinical practice. So using both of these vehicles as we're trying to do at our centers, rather than relying entirely on one or the other. I'd like to acknowledge the funders of our various projects, as well as our centers and research staff and the students, and certainly Farhan. Big thanks and congratulations on this excellent paper. If you have any questions about the complex statistics, I would defer to Farhan, who did all the heavy lifting there. And it really does take a village to do this research. So I appreciate everyone that contributed, and of course to the patients as well. So I'll leave it there, and wanted to keep it short and sweet and open it up for questions and comments.
Thank you very much indeed, Josh. Thanks for getting through a lot of data. That's really very, very clear. We've got some questions in the chat, and we'll come to those in just a moment. I'd like to kick off, if I may, with just a couple of questions about the study, and in particular, just looking at the dropout rate. So a third of your sample didn't have a measure at the end of their final assessment, and I just wondered if you think that there's that reflects sort of disappointment or some other aspect. Do you think that there's and is there a way of treating this data that can get around that?
Thanks, and great question. So the main issue actually was related to the virtual at-home completion of those scales at the last visit. So the initial assessments are done when they come to the clinic for their ketamine infusion. So their baseline is right before their infusion. When they're there, we hand them the tablet, they answer all the questions. But with the final one, that's when they're following up with me. Because of COVID, that's done virtually primarily right now, where they're emailed a REDCap link and they complete it at home. So it's really up to them, and there's no enforcement of, we encourage them. The admin are always calling and saying, please complete it. But that was the main issue with it, with why we had the reduced response. I did look at sort of who was responding and who wasn't. It didn't look like there was a good representation of that. There was a bias towards non-responders not completing. It seemed to be more random random just based on, people's technological abilities and things like that. Looking at the previous time points and the general trend of improvement across time, including when we had the lower amount of missing data, I think also provides some encouragement that the numbers are probably not that far off. But unfortunately, there isn't really a robust, rigorous way to do that. And using multiple imputations or last observation carried forward, none of those I think are good ways of treating the data or doing it justice. So yeah, unfortunately, it's a limitation and a question mark. My general sense looking at the sample, and if I didn't mention it before, these are my patients. I treated probably around 55 of the 66 personally. So my sense of that it was fairly representative, even though there was that dropout in the data collected.
That's great, thank you. I'm an old age psychiatrist by training, and the whole issue of sort of dropouts and retrieved dropouts and last observation carried forward is a nightmare. And in most papers, in most Alzheimer's papers, you get both the completers and the last observation forward analyses presented. It's quite interesting. Okay, let's go to other people. Okay. Yeah, so as always with these, people who ask their questions early get a better shot at it. And I know this is a bit tangential to your paper, but you did reference using psilocybin in your clinic. Do you want to say anything about that?
Yeah, just briefly, with one of our clinical trials that we've enrolled our final participants near complete, we included both bipolar and unipolar. And we have 4 participants with bipolar that have received psilocybin-assisted therapy at full psychedelic doses, 25 milligrams for those who are familiar with the doses. There actually hasn't been any treatment emergent mania that we've observed with it. And there's been fairly robust antidepressant effects in 3 out of the 4 participants, so fairly encouraging. And we were just awarded a grant to do a prospective clinical trial specifically in treatment-resistant bipolar depression, where we're also looking at functional MRI and emotional regulation with neurobiology as a primary outcome. But of course, we're going to be keenly looking at clinical outcomes as well. So that's going to be a 30-person clinical trial with bipolar depression. And it's a big question in my mind of if with both ketamine and psilocybin, if we're being overly cautious here and depriving some of the most severe depression cases from potentially some of the most effective treatments. So doing this cautiously and in rigorous research, I think is an important thing and something to sort of stay tuned, hopefully for some positive data and safety if that comes through in the next couple of years.
Okay, that's really exciting. And sort of relatedly, was any therapy offered with the IV ketamine infusions?
No, nothing routinely. Patients are encouraged to continue to follow up with their usual providers. I'd say it's probably a 50-50 mix of people that have therapists that they're seeing. We don't do CAP per se in terms of ketamine-assisted psychotherapy, but we do encourage people, behavioral activation, CBT principles, those types of things, but no formal integration of psychotherapy in our program, nor restriction of psychotherapy.
Okay, and just in case anybody else missed it, can you just remind us what the dosing was and how when it was it escalated after the first one or after the second one? That was slightly unclear from your slide.
After the second one. So the first 2 doses are always 0.5 milligrams per kilogram over 40 minutes, and then there's a potential to increase to 0.75.
Great. And can you say anything about the Husain disability scale? Just to say a bit more about it. Scott Smith's asking about that.
Yeah, I'm not sure what specifically, but it's basically a 10-point Likert scale on the 3 domains, and it's self-report in terms of the severity of their functional impairment in the 3 domains. It's a scale that is used by big pharma in clinical trials and is often reported as part of the FDA package submissions. So that's seems to be the go-to for function, but as a self-report function scale, it definitely has its limitations. So there was the functional improvements subjectively, though, even though we don't have the objective measures, and that was specifically in the family and social domains, but not the work domains. admittedly, large majority of this group are on disability, and when they go through the infusions, it's pretty rare for them to be returning to work, even if they're doing symptomatically a lot better.
When you say they're on disability, do you mean they're on disability benefits?
Yeah, either off work without benefits or on disability benefits.
Okay. And so you pointed to the limitations of the self-report functional scale. Obviously, function is of incredible interest to payers. In the trials that you've got planned and underway, are there other functional scales that you prefer, or that you have added as well as the Sheehan disability scale?
Yeah, the Sheehan is still my my go-to. I think we might have added one or two other ones to try to capture a bit more. But the Sheehan is still my go-to, just because that's the one that the FDA seems to consider the most.
Okay.
Yeah.
And did you, I mean, just sort of relatedly, obviously you've shown an effect on the social and family scales, subscales, but not the work subscale. And of course, from a pharmacoeconomic point of view, the work subscale is easier to sort of quantify, isn't it? Is there a way, do you know of ways of quantifying the effects, from an economic point of view on the social and family scales, subscales?
Yeah, there is some additional questions and questionnaires relating to specifics of absenteeism and presenteeism, where you're actually specifically quantifying number of days present at work and also function at work. So I think it's the WPS is one that we had used before, but because it was long and we already sort of published those results, we stopped using it. I think that is the one that we're also using in our clinical trials, but I'd have to double check. But that one does provide a bit more objective measures and can be helpful in terms of cost effectiveness, in terms of actual, additional days worked with when being treated with ketamine.
And do you have a sort of resource utilization scale that you use for capturing, how many visits to the doctors people have and how much services they use, that sort of thing?
We don't have a scale. Locally, how we usually do that is with our clinical trials, we integrate them with a database that is the billing database for provincial billing. So you can actually see that data of how many emergency room visits, how many doctors visits. So that's sort of an additional analysis, but there's been some fairly good high impact papers using that database, and relatively easy to just take your participants' health cards and match it up to their provincial claims, since we have the public insurance plan here. So that's the way that we would usually do it, and it could do a fairly robust analysis that we hope to do, but we need the collaboration from the owners of that database as well.
From the agitated and mixed patients, do you increase the dose or do you keep it at 0.5? In Genus's practice, he says higher doses of worsened mixed episodes, and you highlighted this, so obviously you were worried about that as well.
Yeah, so in the 0.5 to 0.75 range, I haven't seen a lot of worsening of the mixed features, but beyond that, our clinic would go up to 1.0 sometimes. Beyond that is where I've run into some issues where there's been clear worsening of mixed features if we went up to, for example, 0.9 milligrams per kilogram with the higher dose protocol. So with increasing the dose of the third infusion, we'd still be guided by if there's an adequate antidepressant effect. And from a tolerability perspective, we would also be looking at are the mixed features getting worse? Is the agitation getting worse? So if it was, then that would be something that would likely prevent us from having the dose increase. But that's interesting to hear that you've had the same observation, because certainly at the higher doses, I've seen that more than a few times.
So I'd encourage, I think that's the end of the questions that I can see that people have asked on chat, but if you've got a question that you'd like to ask, please do put your hand up and we'll talk about it.
I may have a couple of questions in the meantime that maybe our audience is thinking up. Thank you, Joshua. It was a terrific talk and very encouraging data. Overall, I was just wondering, I think you may have mentioned it, and sorry if I missed it. Did you require your patient to be on a mood stabilizer to take PAR?
We recommend it, but we don't require it.
Okay. So they were not all, so when you were saying that they should have failed at least 2 medications in the current episode, you were referring to antidepressants, I guess?
No, to guideline congruent bipolar depression treatment. So using our local Canadian guidelines, which includes both mood stabilizers as well as antidepressants, but we would want them to have failed at least 2 first-line options, so antipsychotics or mood stabilizers. The situation where they're not on a mood stabilizer typically would be these people who have tried dozens and have also had crazy side effects to everything, where they're saying these have had no benefit for me and have only caused side effects. So I'll take my chances, basically, because I don't want to go back on something that's caused side effects. So that would be more the situation rather than people who haven't had the trials and are not on anything.
Right.
Pretty uncommon in our sample and in general. Yeah.
I think somebody has a question. I see this in the chat.
Any concerns about patients who've had previous psychotic episodes?
Not, I mean, a theoretical concern, yes, but not an observed risk factor from what I've seen in terms of risk of treatment emergent mania or worse outcomes. So definitely something that makes us follow quite closely and see if there's any treatment emergent psychosis, but we've never seen any treatment emergent psychosis.
So sorry, I'm not sure I caught this. People with depressive psychosis weren't excluded or were excluded?
So you can't have active psychosis at the point of the treatment or within the past 3 months, but history of psychosis, whether it's mania with psychotic features or depression with psychotic features, is not an exclusion, just no psychosis within the last 3 months.
So somebody with a nihilistic delusion would be excluded?
That one, I think is tricky, right? If it's a true delusion, then yes. But if it's sort of on the border of that severe hopelessness, then sometimes we would include them. So yeah, that's a nuanced assessment. But yes, if it is considered a true fixed false belief delusion, then we would not be able to do the treatment.
Okay, thanks. Tigran comments, the low number of manic episodes is really surprising. Were these mostly in bipolar 1? Did you see any mania in the 4 psilocybin participants?
So with the psilocybin participants, one point to clarify, it's only bipolar 2. Health Canada said, do bipolar 2 first, and then we'll talk about bipolar 1, which I'm actually happy about because it'd be hard to sleep at night. So yeah, it was exclusively bipolar 2 for the psilocybin, and we did not see any treatment emergent mania or hypomania. And then for the low number of manic episodes, is really surprising. Were these mostly in BD1? So it was 3 treatment emergent hypomanic cases. And I believe 2 of them were bipolar 2 and 1 of them was bipolar 1, but I think in a group of 3, it's considered too small to draw many conclusions.
Okay, all of them were receiving racemic ketamine, weren't they? That's correct.
That's correct.
Okay.
In this sample, we have treated with nasal S-ketamine, but in this sample that we presented, it's IV racemic ketamine.
And just, do you want to give us any subjective commentary on your experience with the nasal spray and the racemic intravenous version?
My sense has been that the IV is much more reliable. I've had much more reliable and more robust and more prolonged antidepressant effects across the board with it. We actually don't offer the nasal S-ketamine at our centers anymore because of a number of logistical challenges that I think, many of us have experienced with just working with the supplier, but also because it seems to be inferior clinically compared to the IV ketamine. I'm very interested to hear, Rupert or other people's thoughts on the comparison, because it's certainly, we're all dying for a good high quality comparison, but clinically it seems like most of us are in agreement that the IV is the gold standard and still king.
Yeah, well, if anybody wants to chip in on that with their experience, particularly if they think that S-ketamine is better, then it'd be great to hear from you. Somebody asked a good question about managing high BMI patients. Did you just stuck to rigidly to the per kilogram thing, or did you have a sort of fudge factor in there?
Well, we stick to the per kilogram. This was a sort of long discussion back and forth with our anesthesia colleagues as well, in terms of if we should do ideal body weight versus just body weight, and we came to the agreement we're just going to be consistent with kilograms. We weigh them that day. That's going to be what we use.
Do you think that the high BMI patients do better?
I think that higher weight leads to higher doses. That likely is a contributor of doing better. That's been my general impression. We did do an analysis on our data, which suggested that there was not an association, but it might have been an issue of power. And that was with the entire sample, including both bipolar and unipolar, where BMI was not associated and with improved outcomes. But depending on how you look at that, where BMI is associated with negative, with reduced antidepressant effects and poor prognosis in general. So if higher BMI people are doing just as well as low BMI, you could say that, that's a good thing in itself, since usually the lower BMI people are doing better with their treatments with a better prognosis.